morning, everyone. We'll be starting in 10 minutes. Magandang umaga. Hi everyone, we'll be starting in 5 minutes. Maraming salamat. Good morning. Good morning, everyone. Magandang umaga. Welcome again to the COVID-19 Monitoring Toolkit, Unlocking Faster, the science behind Faster platform. Today is the second day of our 3-day series, where we will be listening to the science and math behind the analytical tools that have been developed by the Faster team since the disease surveillance platform was revived last March 2020. Some important reminders for everyone. Please do not forget to accomplish and submit your evaluation forms at the end of the session. Your certificates will be sent to you via email using your registered names. Don't forget to mute your microphones and turn off your cameras to preserve bandwidth for the speakers. And stay until the end of today's session for a group picture. May class picture tayo sa dulo, no? And without further delay, I will now call on Dr. 𝗫𝗏𝗏 to introduce the speaker who will open the session for today officially. Magandang umaga, ma'am.
Good morning, Andre. Salamat. Good morning to everyone. Allow me to introduce our special guest from the Department of Health. Thank you, ma'am, for agreeing to open our session today. Undersecretary Dr. Lilibeth has been working for more than 25 years in the health sector. In her extensive experience across the different departments of the Department of Health, she has been integrally involved in the drafting of key health policies and systems and their monitoring and evaluation. She is currently the Undersecretary of the Health Facilities and Infrastructure Development Team, a functional team composed of 6 bureaus and offices tasked to ensure the development of policies, standards, and guidelines for health facilities and infrastructure development, including information and communications technology and the Dangerous Drugs Program. She is also the chair of the IATF Sub-Technical Working Group on Data Analytics, an interagency group that provides accurate and timely analysis of all relevant data on COVID-19 and corresponding policy recommendations to the IATF. We welcome Usec Lilibeth. Good morning po.
Good morning. Naririnig ba ako?
Yes, Usec.
Okay. Good morning to everyone, and congratulations again to the Faster team for organizing this. I will be discussing today a quick overview on the targets and directions, especially on improving health system capacity, the principles which were used as basis for the models developed in the Faster platform program. Next slide, please. So this curve has been shown numerous times to explain the COVID-19 response, specifically to keep cases to a point wherein cases are manageable for the health system. This curve highlights the response has 2 equally important goals. One is reducing transmission, and the other is improving the health system capacity. Discussions yesterday talked about the principles of measuring transmission. What I will go through briefly today would be the principles behind our assessment of the health system capacity. Building health system capacity cuts across both primary and community care and hospital inpatient care. At the primary level, important components include contact tracing, capacity and efficiency, community isolation capacity, testing capacity, and community health workers, including epidemiology and surveillance personnel. At the hospital level, important components include the infrastructure and equipment for isolation, moderate to severe care, critical care with ICU and mechanical ventilators, and appropriate health care workers, including doctors, nurses, and allied health professionals. But what we also want to highlight here is that both primary care and hospital care cannot work in silo. An LGU-led coordination and referral mechanism is necessary to really ensure we meet our desired health system capacity outcomes. Next slide, please. When we talk about health system capacity, we mainly talk about structures and systems that need to be in place to reduce infectiousness at the primary care level and treatment and death at hospital level. Later, the FASTER team will discuss how they incorporated these principles into mathematical formulas, but the general principles are the same. The general population, which are susceptible, will reduce exposure if they limit movement and comply with minimum health standards. The exposed will reduce infectiousness if they are immediately isolated. The infectious will be confirmed cases if they are tested, and confirmed patients will be recovered if they receive appropriate treatment. Next slide, please. To enable improvement of health system capacity, the DOH set these minimum health system capacity targets for preparedness. This is not the comprehensive list. Details can be found in AO 2020-0016. But the following are the main directions that the DOH set forth to put in place. Targets we met include from only one laboratory in ITM last February, we now have 84 RT-PCR laboratories and 27 gene expert labs. Most DOH hospitals and tertiary hospitals across all regions have been designated as referral hospitals. The minimum isolation capacity of 1:2,500 population as a whole has been met, but will need to be expanded, especially in areas with increased cases such as NCR. The rest are targets we are on track to achieving, including increasing ICU and mechanical ventilator capacity, dedicated beds for COVID-19, including their corresponding personnel, surveillance and contact tracing capacity and efficiency, and coordination centers in each LGU. Next slide, please. The COVID-19 response encompasses these 5 main strategies: prevent, detect, isolate, treat, and recovery. Capacity is necessary across all components and in linking both community and hospital care. Measuring progress and projecting this capacity is important in guiding our national response, including measuring them in consideration of other factors such as social, economic, and security considerations. Thank you very much for your attention.
Thank you, Usec. Thank you for opening the session for today. Please stay on now if you can to listen to the presentations, because today we have 2 important topics. One is we will discuss all the non-health related indicators, aside from, of course, discussing health capacity. And then second would be the age structured model, which we have been developing with our WHO partners. So good morning po, and welcome to our very simple conference po. Thank you. Okay, so let us continue with today's session by allowing me to introduce our presenters. So our first session is on health, security, and economy. And we have 2 presenters for the first presentation. First, Dr. Elvira P. de Lara-Tuprio, or Elvi, is the mathematical modeling team lead of the Faster Than COVID-19 project. She is a professor of the mathematics department of the Ateneo de Manila University. Her areas of research include integration theory, disease modeling, and financial mathematics, particularly financial derivatives and risk management. Aside from teaching and research, Dr. Elvi also writes mathematics textbooks for both high school and college. She is also a consultant for a number of local banks and has served as third-party validator of their risk management models. Allow me to also introduce the next speaker. Dr. Raymond Francis R. Sarmiento is a physician, scientist, and currently the director of the National Telehealth Center, National Institutes of Health, University of the Philippines, Manila. He is also a clinical assistant professor of the UP College of Medicine's Medical Informatics Unit and is the current president of the Philippine Medical Informatics Society and chair of the Health Informatics for Development Working Group of the International Medical Informatics Association. As part of the FASTER team, he leads the data warehousing team, including interoperability efforts of the government related to COVID-19. Dr. Sarmiento graduated from the University of the Philippines College of Medicine in 2008 and finished his Public Health Informatics Fellowship from 2014 to 2016 in the Division of Surveillance, Hazard Evaluation, and Field Studies at the National Institute for Occupational Safety and Health at the U.S. Centers Disease Control and Prevention. Prior to joining the US CDC, he completed his postdoctoral fellowship in clinical informatics from 2012 to 2014 at the Lister Hill National Center for Biomedical Communications, National Library of Medicine at the U.S. National Institutes of Health in Bethesda, Maryland. Last year, he was awarded by the National Academy of Science and Technology, Philippines as the 2019 Outstanding Young Scientist in the field of Public Health Informatics. Let us now listen to their presentation entitled Projections on Health Systems Requirements. Thank you.
I will share screen. Okay, good morning, everyone. So in this talk, we will present to you how we use the mathematical models to obtain projections of the health system requirements in the different LGUs. Okay, so with me again is Dr. Raymond Sarmiento after my talk. Okay. Allow me to begin with a summary of our talk, because this will give the message, okay, of what our mathematical models really intend to produce. Community quarantine, the ACQ, GCQ, and so on, has been quite effective in reducing the spread of disease in the country. However, it cannot be imposed for a long period of time because of its huge economic cost. It should be used only temporarily in order to allow the health system to prepare or improve. Okay. Based on the output of the SAIR model of FASTER, what must be considered in the government's effort to quote-unquote flatten the curve is really the level of health system capacity, meaning the capacity to test, isolate, and treat patients, whether suspect, probable, or confirmed. In this talk, we will present how the SAIR model shows the effect of the different levels of HSC on the projections of COVID cases, as well as the number of tests required per day. This is important for the LGUs, and the required provisions in hospitals and community facilities in order to meet the requirement needs of patients. Okay. The latter include the number of beds, ICU beds, cohorted beds, and so on, healthcare workers, and PPEs. Okay. Yesterday, the team explained to you the SAIR model being used by FASTER. It is in fact just one of the models that we are using. Okay, so in the SAIR model, we have compartments for susceptible, those who are not yet infected; E, exposed, those who are infected but not yet infectious; and then the undetected infectious individuals. They are the infectious asymptomatic and infectious symptomatic, then confirmed and recovered. Okay. And we also showed you that among the parameters that we use in the model, we pay particular attention to this transmission rate beta. Okay. Using this parameter, we measure the effectiveness of community quarantine and the minimum compliance to the minimum health standards. And then the delta S here, from IS to C, measures our efficiency in isolating the infectious individuals, okay, and as well as the testing and the treatment. Okay. Okay. The isolation and treatment facilities can be broadly divided into two. As Usec David mentioned, we have the hospitals, okay, level 2 and level 3 hospitals, and TTMF, or temporary treatment and monitoring facilities. So TTMF, okay. This infographic taken from a DOH memo describes the protocol for patient referral. Ideally, only severe COVID cases, critical cases, and mild cases with comorbidities should be in the hospitals. Then mild COVID cases without comorbidities may stay in the TTMF, or community facilities. Okay? Suspect and probable, meaning those who are not yet confirmed but exhibiting COVID symptoms, may stay in the TTMF, or temporary facilities. Okay. We will show you here how the SEIR model can be used to determine the number of tests that must be conducted per day, the hospital requirements, and the TTMF requirements. So I'll discuss each of the three items. Okay. For testing, our formula is based on the delta S here. Remember that delta is defined as the percentage of all the undetected infectious symptomatic individuals that must be confirmed per day, okay, or that must go to the isolation facilities per day. Okay, so from that, we have this formula for the number of tests per day. We just multiply the projection of IS for that day, multiplied by delta S, and then divide by positivity rate. Okay, for example, if on a particular day IS is 1,000 and delta S is 20%, then 20% of 1,000 is 200. Okay, so the model says that 200 infectious individuals must be transferred to the confirmed compartment per day. However, we don't know who the infectious, remember the IS are undetected, we don't know who they are. So we have to conduct several tests in order to meet that 200, to see that 200 people. And in order to expand the number, we just divide by positivity rate. So for example, if the positivity rate for that day is 10%, then we divide IS times delta S by 200, meaning by 10%, meaning 200 times 10, there should be at least 2,000 tests conducted for that day. So that's how we got the numbers here. This is the number of tests per day on a particular, for a given particular scenario. Okay. Of course, there should be workers administering the test, and then they need the diagnostic PPE sets as well as outer globes. So from the numbers produced in the SEIR model, we come up with estimates for the number of tests that must be conducted on a particular region or municipality or province or city for that day. Okay. Next, hospital requirements. Okay, the items that must be available or that must be provided are the ICU beds, regular beds, and ER beds. Okay, we determine the numbers here based on our projection of the confirmed cases. Our assumption is that 80% of all confirmed cases are asymptomatic, although it's lower than the 90% in the DOH data drop. Severe is 14%, critical is 6% of all active cases. So based on that assumption, we determine the number of ICU beds, regular beds, and so on, the number of doctors in ICU, regular, and ER, based on additional assumptions about how many patients they can handle per day, per 8-hour shift, and then times three shifts in a day. Okay. We also determine the number of this is nurses. Okay, number of nurses in ICU, regular and ER, proning personnel, respiratory therapists, ventilators, suction machines, medtech, venous, arterial, and PPEs. So we obtain these numbers based on our projections of confirmed cases and additional assumptions. Okay, and then in the TTMF, okay, the patients here are mild confirmed and suspect and probable. The mild confirmed cases are obtained from the SERR model. For suspect and probable, unfortunately, we just made assumption here based on the IS and IA. Okay, we used IS and IA, and then our assumption of how many they can potentially infect per day. Unfortunately, we don't have enough data in order to validate this, but at least based on the numbers that we obtained, I think our projections of suspect and probable should be the minimum. Okay. Okay, so mild confirmed cases may stay in cohorted beds, whereas suspect and probable, meaning those who are not yet confirmed but showing symptoms of COVID, should stay in isolation beds. And then each temporary facility should have physician, nurses, midwives, barangay health workers or community health workers, nutritionists, pharmacists, food handlers. The numbers here are based on the DOH memo. So from the provisions in the memo, we calculated how many healthcare workers must be present in the TTMF. Okay. Also, we made based on the number of healthcare workers and the projected number of patients, we determined the number of PPEs and surgical masks. Okay. What's the use of these projections? These numbers can help LGUs in planning for their budget, as well as the target number of hospital and community requirements. Okay. In the dashboard, the numbers can be seen through graphs. Okay. So the LGUs can see the requirements per day using this graph. So the first one was for the testing, and then this is for hospital requirements, and then this is for the community capacity requirements. Okay. We now have Dr. Sarmiento. Dr. Raymond.
Thank you, Dr. LV, and thank you for the introduction, Dr. Rina, and welcome to day 2 of our Unlocking Faster conference. This part of the presentation will be talking about the policies and the important message that we want all members of our audience to focus on in terms of health system capacity. For the policies, the ones that have been mentioned in the previous slides, they came from the different department memoranda or joint administrative orders that are shown here in this slide. The ones that have been mentioned are DM 2020-0123, which is on the interim guidelines on the management of surge capacity through the conversion of public spaces to operate as temporary treatment and monitoring facilities, or TTMF, for the management of persons under investigation in mild cases of COVID-19. This was issued March 16th of this year. 2020-0178 talks about interim guidelines on healthcare provider networks during the COVID-19 pandemic, and this definition of HCPN is taken from the Universal Healthcare implementing rules and regulations. So this focuses on the healthcare facilities that will be providing healthcare services to those who are afflicted with COVID-19. And finally, we have the Joint Administrative Order between DOH and the Department of Interior and Local Government on the guidelines on local isolation and general treatment areas for COVID-19 cases, Ligtas COVID, and the community-based management of mild COVID-19 cases, issued April 15th,
2020. Next slide, please. So for healthcare utilization, what we have in FASTER provides not just the national summary, but also at the local government unit in terms of the utilization of the different beds in the bed wards, in the regular wards, in the isolation facilities, isolation beds. We also have beds for ICU and for the use of mechanical ventilators. This is as of August 22nd. So yan po yung nung Sabado. And this shows po that we are, at least for the beds for severe cases, we are in the orange zone. And for critical care, we are in the red zone. So the next slide po will show what the different zones are. So in terms of percentages, it's considered that you are in the safe zone if it's between 0 to 30% utilization. Warning zone will be between 30% to 70%, and danger zone, yung po talaga yung malapit na po tayong ma-overwhelm, if not already there, 70% to 100%. The FASTER dashboard also allows the user to be able to view the different healthcare utilization components based on a particular hospital po. So this is distributed according to region, and also based on the provinces or highly urbanized cities or independent component cities. So in the next slide, you will note also that this is our current scenario, at least for the National Capital Region. So you will note a few weeks back, this was before the return or the re-escalation to MECQ of National Capital Region along with yung mga pong nearby regions. There was a clamor from the coalition or alliance of healthcare professional, the medical societies po, and they termed it as a timeout. So this represents our current situation right now in terms of healthcare utilization. Mapapansin niyo po, there's a lot of red and a lot of orange in terms of the healthcare utilization. There are certain areas po wherein we do not have data, and that is represented here in with regards to the gray areas that are shown here. And in the next slide po, we wanted to look at the testing capacity. So not just the availability of the facilities and all of the different elements that go with it, but also how we are faring in terms of testing. In my final slide, I will show po how that goes about. But at least for this slide, I go in this slide po, wherein we got it, the data that we got from the DOH COVID-19 tracker. It states here that we have to date tested 2,338,607 samples with a little less than 2.5 million remaining available tests. And we have already tested a little over 2.1, nearly 2.2 million unique individuals as of August 23rd. What you will note will be the still relatively high positivity rate that we have, which shows 10.5%. The WHO recommendation is the countries should be able to target around 5%. The positivity rate. So it's true that the more you test, the more that the more likely that you are able to capture the ones that are infected with COVID-19. But the positivity rate points to how effective the control measures of the government are. So habang tumataas po ang ating testing, sana po ay bumababa ang ating positivity rate. That will go to show how really efficient our plans po in terms of controlling the COVID-19 spread. You will also note that in terms of testing, the government has really ramped up since the beginning. We already have 106 accredited testing labs all across the country as of Sunday. So in my final slide, it shows po the PDITR strategy. And this PDITR strategy, it's an acronym. It stands for prevent, detect, isolate, treat, and reintegrate. So this comes from the phase 2. So there are 3 phases po in terms of the action plan by the National Task Force or the NTF for the National Action Plan for COVID-19. It's a multi-pronged approach po, no? And the objectives are several. There are, I think, 7 objectives. Number 1 is to contain and manage new COVID-19 cases in high-risk areas. Number 2, sustain whatever wins we got against COVID-19 and continue best practices. Number 3, and this I think primary, not just for the health sector but for the non-health sector, balancing the nation's health and economic welfare. The 4th one is to localize COVID-19 responses by rallying people's support and participation. Letter E will be to keep our relatively low case fatality rate, including the non-coronavirus cases. 6 will be institutionalization of the PDITR strategy, including the zoning containment strategy, wherein there are enhanced and localized zoning containment moves in terms of containing the different cases. And finally, the last one is to focus and concentrate the efforts on expanded and targeted testing and contact tracing. And that is why for phase 2, there is an intensified implementation for a more focused, faster, more effective, and more efficient implementation of the 4 major prioritized strategies, which is as shown here on the right-hand side: testing, tracing, isolation, and treatment. So you will note po that the government has assigned different czars for each of the TTIT po na nandito. So for the testing czar, we have Secretary Vince Dizon. For tracing czar, we have Baguio City Mayor Benjamin Magalong. For isolation czar, we have DPWH Secretary Mark Villar. And for the treatment czar, we have Health Undersecretary Dr. Bong Vega. So a lot of these efforts really have been concentrating on the different aspects. But in terms of really ramping up how we are doing this, if you will go back po, lalo na po sa mga nagbabasa po ng ating mga IATF resolutions, ano po, in IATF resolution number 47, which was issued last June 19, 2020, in particular, there was mention po, and this was specifically at least for the province of Cebu, the establishment of outpatient services in existing TTMFs, dahil po mababa po ang utilization ng mga TTMFs at tumataas din po yung number of isolated individuals at the home. That's why yung mga subsequent po na policies have been, even for those that are mild or symptomatic, if they can be put in isolation facilities, that would really go a long way in terms of containing the spread of the disease. Also, hindi po siya sequential. Hindi po kailangan po na matest ka muna bago po siya ma-isolate. That's very, very important. That's one of the things that we wanted to share with everybody, is that let's have a mentality that you already have the disease. The reason for that is because you want to be able to quickly and more efficiently isolate yourself. Having that mentality po kasi will make you more conscious. Not necessarily you really have to be overly concerned or overstressed out po in terms of having that concern na meron na kayong virus, but it's more of, from a public health perspective, being able to on an individual level motivate the people to think about very, very consciously every step of the way to wear masks, wear face shields, physical distancing, regular washing of the hands. All of the minimum health standards po kasi, mas lalo po siyang napapaigting, mas lalo po siyang parang na-cement or na-stamp po sa ating mga isipan kung kayo po ay meron pong ganoong mentality. At hindi po, ulitin ko lang po, hindi po kailangan po na kayo po ay mag-test, matest at magresulta ng positive bago po kayo mag-isolate. Kailangan po, as soon as you feel anything, any of the symptoms of COVID-19, or you feel that you have had an exposure to suspected case, kailangan po you have to do the due diligence on your own po to isolate yourself. The government has been focusing po on the treatment, but I think it's time also that as much as we have focused on the treatment, which has been commendable, really the focus will be on the prevention. As mentioned, an ounce of prevention is worth a pound of cure. Maraming salamat po, and we will be more than happy to answer your questions.
Thank you, Doc Raymond. Yes, to everyone, please feel free not to type in your questions in the chat box, and then we will entertain all the questions at the end of the presentation of our third presenter. Allow me to now introduce our next presenter, our next resource person. Our next resource person is a surgeon and a police commissioned officer. She graduated from medical school in 1999 and took her residency training in general surgery, where she won several awards on her research paper. After her residency, she served as a consultant in different hospitals for more than a year. After years of study and training, there's this childhood dream that she wished someday would come true. On December 2008, she joined the Philippine National Police via lateral entry. Life of a police trainee is no joke, but it did not stop her from fulfilling her dream and finished Public Safety Officer's Basic and Advanced course. Being a surgeon in the PNP is demanding, but she has always believed that learning is a continuous process. Thus, she took and completed her master's degree in management major in hospital administration in 2016 and hospital administration executive course in 2019. In 2018, she embarked on her first regional assignment in the land of the brave, Bangsamoro Autonomous Region in Muslim Mindanao, during the height of the martial law, where she had the privilege to serve the people of Mindanao. During this health crisis, she spent long hours working alongside with health care workers and dedicated herself in providing service to all who needed surgical care, as well as to the PNP personnel who are our frontliners. Recently, in social media, she was tagged as the hero cop that went trending on Facebook for her good deed as the surgeon who took a patient in and cared for after several hospitals rejected her. Because of her passion to serve, she was chosen to be part of CBRNE under the Directorate of the Operations Philippine National Police. This unit is comprised of highly trained personnel specialized in CBRN-related incidents. Ladies and gentlemen, the Deputy Chief of Chemical, Biological, Radiological, Nuclear, and Explosives, Police Major Ana Marie L. Cabasal. Good morning po, Doc.
Thank you for that kind introduction, Ma'am Rina. Good morning, distinguished members of the panel and all the concerned professionals from the different civil society organizations, government, researchers, academia, media, healthcare organizations, and other stakeholders who have gathered here today for this seminar. Thank you for taking the time off to join us. Next slide. In the Data Analytics Sub-Technical Working Group, we present information in 5 areas, including health status, which describe trends in the spread of the disease, health capacity, which describe the status in testing, trends in the spread of the status of the hospital or isolation facilities, social economic status on the locality, and security. Next. If we define security, it refers to all the measures that are taken to protect a place or the quality or state of being secure, such as freedom from danger. I will be presenting the approved security measures or parameters that has been considered as a decision tool, and it's categorized into 2 classifications, the major and the minor crimes. There are 6 indicators for major crimes, and these are incidents of A-focused crimes, domestic violence, relief snatching, harassment from the communist terrorist group, arrested persons on anti-illegal gambling, and anti-illegal drugs. We have 7 indicators for minor crimes: curfew, disobedient violations, incidents of hoarding, profiteering, manipulation of prices, public utility vehicles apprehension, assault, discrimination against frontline workers and government, arrested persons for selling, using fake ID cards, IATF pass cards, travel pass card for exemption for community quarantine, arrested persons on liquor ban, and lastly, the violation on publication. This is the misinformation post on COVID-19 through social media. These minor crimes are more directly related to COVID-19 interventions. Next slide. We do our data collection by assigned PNP personnel from the level of regions, province, 𝗖𝗃𝗃𝗃𝗃𝗃. They encode their data on a weekly basis per indicator via online. Data will be assessed by the FASTER platform and the scoring system. Next slide. For each indicator, a score of 1, 2, or 3 is given, depending on the number of crimes or violations recorded. This is per incidence. This guide will show us on how to know the level of risk in such areas by regions, province, highly urbanized city, or independent component city. Under these crimes are scores according to the number of incidents per million populations and will be interpreted on the level of risk. The scores for the 2 categories are then aggregated with the score for major crimes, given twice the weight as the score for the minor crimes to obtain the classification of the said areas. Next slide. The sum of the scores for each category is then obtained. If the sum is less than 5, then the area is classified as low risk. If the sum is from 5 to less than 9, then the area is classified as moderate risk. And if the sum is 9 or higher than the area is classified as high risk. The objective of this is to determine high-risk areas for effective and timely mobilization of security personnel for increased visibility and response during the community quarantine. Next slide. In this table, you will see that the indicators are represented with a cutoff range. Again, that will depend on the total number of incidents per million populations. The weight of the score is dependent on the number of violations on the parameters. Next slide. Same as minor, and it is also represented with a cutoff range. These major crimes itself is being closely monitored even without the COVID-19. Next slide. This is a sample interpretation between the National Capital Region and Region 2 with their raw data. Next slide. If you analyze using this, the minor crimes on both regions is on a high risk classification. Comparing both on major crimes, Region 2 is classified as high risk, while the National Capital Region is on a moderate risk. Next slide. This is a sample view of the security index that you will see in the FASTER platform. Next slide. Thank you for listening.
Thank you, Doc Marie. Please stay on because we will have our Q&A afterwards. Baka po may mga tanong ang ating participants. Maraming salamat po. Magandang umaga. Okay, so we are now down to the third and last presenter for this morning, and that afterwards we will proceed with our Q&A. Okay, our next presenter is a PhD student at the Massachusetts Institute of Technology, where he is also an MIT Presidential Fellow for 2020 to 2021. He was formerly a lecturer at the Department of Economics at the Ateneo de Manila University, where he continues to be active in various research engagements. Among others, he has led or extensively contributed to research studies commissioned by the Asian Development Bank, the International Labour Organization, the 𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏 Foundation's Research Institute for Social Development. He has also served as a consultant to the Department of Trade and Industry, the Department of Agrarian Reform, and the Philippine Institute of Development Studies. Prior to his academic work, he served in the government civil society coalition that legislated and implemented the Philippines landmark Sin Tax Law of 2012, which was funded by the country's Universal Healthcare Program. To our participants, let's all welcome Jerome Patrick Cruz. Jeric?
Hi. Yeah. Good morning, Dr. Rina. Good morning to everybody. Allow me to share my screen. So just let me know if this is visible. Is it clear? Saving lives for the economy already?
Yes, we see it, Jeric.
Okay.
Go ahead.
Right. Fantastic. Thank you so much for the introduction as well as the opportunity to share with everyone. I know my time is limited, so I'm just going to cut to the chase by starting with some questions which are on most of our minds and have been on our minds for the past few months. And the questions are, number one, in order to save lives from the COVID-19 pandemic, is it necessary that we have to tank our economy to be able to flatten the curve of COVID-19? Do we have to compromise livelihoods, people's livelihoods of millions and millions of Filipinos? Now, we want to echo what Doc 𝗤𝗃 de Lara-Tuprio, as well as Dr. Raymond Sarmiento presented earlier. Economics is normally known as the dismal science, but we try to apply rigorously several economic tools of analysis based on the FASTER SCI model, as well as other economic tools. And what we find is that this so-called trade-off between lives and the economy can be overcome, especially if we focus on increasing our health capacity. So I want to share with you some of the steps that we've done to be able to come to that conclusion, some of the indicators that we've put together and are in the process of uploading to the FASTER platform, and hopefully some of the conclusions and recommendations that stem from this analysis. So before I move forward, I do want to provide an acknowledgement. This is not just me. There are so many people, and I'm not even necessarily the most important person on the team as at this point in time. So we have a team of many different individuals, faculty, researchers from the Department of Economics. I do want to extend a thanks to Dr. Rina Estuar for inviting me and Professor 𝗤𝗃𝗁 𝗏 for actually to explore using the FASTER projections and data to be able to come up with this kind of analysis. The Department of Economics of Ateneo de Manila University has also been a strong source of support and has really pulled no punches in terms of providing the kind of resources and institutional backing that we need. And finally, we also do have a partnership with UNDP FinTech Lab in terms of coming up with many of these metrics, which is something that we see as continuing to evolve over the next few months. Now, to put everything in perspective, I think this is something which is familiar to most people. But the idea is, for the longest time, and this is a debate which has been raging on ever since the start of the community quarantine also in the Philippines, that there is a trade-off, supposedly, between the economy, as well as saving lives. And the idea is that on one hand, in order to flatten the curve of COVID-19, there has been, especially in the early part of the pandemic, a lot of focus on lockdowns and containment policies to be able to reduce the curve from this height here to a more manageable spread, as you can see in the bottom. However, the downside, allegedly, is that to be able to do this, there is a cost to the economy as well. So whereas if you don't apply your containment policy, your economy will not necessarily will suffer a hit, certainly from COVID-19. But if you do apply like a lockdown, there's supposedly going to be a much heavier source of damage to your economy during that entire period. Now, this is not just us or many other commentators. It's been mentioned in the Philippines, it's been mentioned at the global level. And to give you one example of groups which have actually tackled it head on for developing countries, I can quote from a recent report of the World Bank over here, which emphasizes for developing countries, the trade-off is not between lives and the economy. It is about preventing deaths from COVID-19 versus avoiding crushed livelihoods. And I highlight this, the debts flowing from those crushed livelihoods. And we can see this very much in the Philippines. I think it really needs no mention that if you look at the state of the Philippine economy, I could go on for 30 minutes if you want me to elaborate upon these. But on one hand, joblessness has been at the record high, the highest we've ever been, ever since we started recording the labor force surveys in the country. And if you look at the recent SWS metrics, which came out this month, supposedly we now have 45% of adults who are currently now jobless because of the pandemic, as well as the measures that we've taken over the past few months. And if DTI also conducted a survey, and supposedly quite a few businesses closed also during the lockdown during that period. Now, I want to jump forward to our conclusion, just to really emphasize that we are not on the side of those who are against saving lives. In fact, we believe that we can do both, saving lives and the economy. But the most important measure that needs to be done is exactly what's been emphasized by the FASTER team. We need to improve our health, isolation, and treatment capacity. This offers the way in which we can overcome the so-called trade-off between lives and the economy. Now, to be able to come to that conclusion, we had to undertake a whole variety of steps. And I'm not going to go over the technicalities because I believe that would take too much time, and I only have a limited period. But I want to share with you the highlights which were relevant to us arriving at our particular conclusion. So ever since May, we've been focusing on 3 particular steps. Number 1, we wanted to expand the framework for developing a social economic portal in the FASTER website. We wanted to, at the same time, ask this framework to develop a socioeconomic risk index similar to the security index, which has been presented earlier. And using the indicators which were available, both in this framework as well as this risk index, model the trade-offs between different levels of community quarantine, as well as the impact of increased health, treatment, and isolation capacity on this total socioeconomic costs that are faced by the Philippine economy. So in terms of the framework, we've been gathering data nonstop ever since May, and over a period of 4 different elements. The first one is what we call the context of what LGUs were facing before COVID-19. So what is the socioeconomic context? Secondly, how were they disrupted? What were the immediate costs that were posed by COVID-19, such as in terms of vulnerable enterprises, in terms of vulnerable employees who may have lost their jobs, in terms of the track record of delivering amelioration services thus far, what has been the case across different LGUs. And then finally, moving into the recovery phase, if you look at the different stimulus bills, how has the local implementation of this fared thus far? Now, there are a lot of indicators over here. I will not have the time to tackle all of them, but I'll just give you guys a flavor of what they could look like. So in terms of the context, if you want to zoom in directly in terms of socioeconomic data, we do now have data which shows down to the highly urbanized city level, as well as the provincial level, what are the different sectors which employees as well as enterprises are located on. So how many, and if you look over here in the FASTER dashboard for NCR, how many are in agriculture in NCR? How many are in manufacturing? How many are in retail, such as malls? How many are in BPO and other administrative support services? So in the upcoming socioeconomic portal, this is one kind of data set that will be available. So you will be able to see where different people work, as well as the businesses which are operational within different highly urbanized cities. We can also look at this not only in terms of sectors, we can look at it in terms of size. Are these micro enterprises, small enterprises, large, medium? Or you can also look at, these are the number of establishments and also the number of employees across different establishment sizes in that particular case. Now, in terms of disruption, what we have done with the team is to try to calculate across different community quarantine scenarios, whether it's an enhanced, modified enhanced, or general community quarantine, what is the level of vulnerability which are faced by different LGUs? And we're able to compute this down now to the highly urbanized city level. Unfortunately, for a municipality, the data is constrained so that we cannot calculate for every individual municipality. But at the highly urbanized city level, we're able to do this by applying the rules on community quarantine to which sectors are able to operate based on what DTI has been able to release. So what do we find? If we have, to give you one example, if you have an enhanced community quarantine in Metro Manila, we estimate that practically 2/3 or 64% of employees would not be able to go to work. If we have an MECQ, we estimate that around 36.1% would not be able to work. So around 1/3. And then for GCQ, if we had a GCQ, around 1/5 still continue to experience challenges in terms of going to work. Now I highlighted different yellow bars over here and orange yellow bars. And the reason for this is because if you look at having an MECQ, such as what we had earlier in August, these are the cities which have a higher than average disruption rate for MECQ. So Manila, Marikina, Caloocan, Las Piñas, Parañaque, Pasay, and Pateros. It turns out that for an MECQ, these are among the most vulnerable cities in terms of how much workers within them would not be able to go to work. So as you can see, we're able to calculate this not only for NCR, but for all highly urbanized cities and provinces throughout the country. Now, we also can tabulate this in the disruption panel based on the size of enterprises. And as you can see, when it comes to MSME, when it comes to which enterprises are particularly vulnerable, it's especially micro enterprises, which are vulnerable. But across different sector, if you look at which employees are vulnerable, they're relatively more evenly distributed, though micro enterprises and small enterprises still occupy a majority of the enterprises where employees are vulnerable. Now, in terms of the COVID socioeconomic risk index, we wanted to use much of the data that we got from the framework which we developed to be able to develop risk indicators. So this is still something which is still being finalized after the moment, but that risk index is envisioned to have 4 different pillars. The first one is population. As we all know, areas with different density and different demographic features may prove to have populations that are more vulnerable to COVID-19. So we want to take a look into which areas across the country tend to be much more vulnerable to transmission spread to begin with. In terms of health systems, this is different from what was mentioned earlier, as well as yesterday, in terms of surge capacity and reaching warning levels. We look instead at recommended benchmarks, say for health personnel to population ratios, or health facilities to bed to population ratio, as a general examination of how health systems were faring in LGUs across the country previous to COVID-19. In terms of LGU capacity, we were very fortunate to get a lot of data from the DILG. So we're putting all of this together, such as the seal of good local governance, their capacity to mobilize local resources, the integrity and the cohesiveness of their disaster risk reduction and social protection systems. And naturally, when it comes to the economy, we look at, as I've already showed you, worker and enterprise displacement. So to give you one example of how we try to classify this, the method is fairly similar to what was presented in the security index earlier, based on a given quarantine level, how many people, so this was for ECQ, how many people are vulnerable, is it higher than the norm? So high, then it translates to high, so on and so forth. So if you have more questions about this, I'd be happy to elaborate in the Q&A. But this is just to provide an example for the National Capital Region. And we've done this for all the provinces as well as the highly urbanized cities across the country thus far. Now, using the framework information as well as the risk index, our goal was to be able to model the different social and economic trade-offs from COVID-19 and the lockdown measures. And we were very fortunate that we were not the very first in the world to be able to do this. In fact, we found that there was a pre-existing, pre-printed study from researchers at the Washington University of St. Louis. And what they were able to do was to be able to model the socioeconomic impact of adopting lockdown policies in response to COVID. So what exactly were they able to do? Well, I will not go into all of the details, but on one hand, they took into account the total economic cost of lockdown. So the cost of health treatment, the cost of death, and foregone labor productivity. And based on a simulation they were able to do from this, as well as an SEIR model, they were able to find that the approach with the least trade-offs is for gradual relaxation, meaning you don't really stop and go very quickly in terms of having an ECQ. It's best to slow down the release of your community quarantine, especially when it comes to vulnerable groups such as for seniors. So what did we do to be able to adapt? There were different features of the Washington University of St. Louis model. So what we did instead, since the faster STIR model was already existing, we wanted to use as much of the work which was already done for that as much as possible. But we did some modifications. Now, I'm not showing the equations, but each of the items over here, which I'm showing to you guys, has a particular differential equation associated with it. So from susceptible and exposed, the idea for those who get COVID-19, we try to find a way to estimate how many people are taken out of the labor force due to the community quarantine. And for those who get COVID-19, who are tested and confirmed, so assuming that they're tested and confirmed, they will need to be isolated. So they will also not be able to work while they have COVID-19. So from this, we have three particular kinds of socioeconomic costs. The first one is that we take a look at the health cost projections. So that's this one over here. So the cost of treating the infected, including the cost of treating the dead, so cremation. And most importantly, because this is the single biggest component, the value of statistical lives lost. So we were able to find some measures of this, but the value of statistical lives lost is a general statistical measure for how much people would value saving the lives of those who have perished. So there are ways to measure that using statistical and economic methodologies. We take a look also at the immediate output and labor losses because of the community quarantine or lockdown. How many people are not able to go to work, and how much will the damage be in terms of GDP loss or economic output because these people are not able to go to work. And then finally, we find that because of COVID-19, because people will get sick, people will take time to recover, and naturally there will be casualties, fatalities due to COVID. So people who suffer because of death and disability will no longer be able to contribute productively to the economy. So that's another long-term loss, which stems from COVID-19. So you add all of these three up together, and we arrive at what we call the total socioeconomic cost of COVID-19. Now, what did we do to be able to calculate this? So we based the treatment cost on PhilHealth rates. The private sector rates differ, and in terms of what we call the HMO plans are vary very dramatically. So we decided to work with the PhilHealth rates. We got a sample of how much it would cost to develop emergency ward beds, emergency isolation in treatment beds, and we were able to get value of statistical lives estimates from a colleague in the economics department, Rosalina Palangkatan, who conducted studies on this on 2013 and 2014. So we simply got the real value of that and we projected it to 2020. Now for immediate, it's quite similar to what I showed you guys earlier. Based on how many people could not go to work, we were able to get that figure and then apply it using economic methods. So we did production function modeling, we applied input-output ratio analysis, and we also have the capacity to do computable general equilibrium and modeling as a robustness check for the numbers that we were able to come up with. And finally, we did something similar, but looking more at those experiencing disability and death for the long-term cost. So similar methods on that front. Now, the trade-off model is still in the process of being finalized, but we were able to come up with some preliminary results from this kind of modeling. And we were very proud to announce that we were able to do this with Pintig Lab, and this has been circulated. We sounded this off also with the FASTER team, and we were able to circulate this with some members of the National Task Force on COVID-19. And we call it Saving Lives or the Economy. And this was done during the period where we were considering shifting to MECQ in Metro Manila. And we tried to look at 4 different scenarios. What would happen across the month of August from August 4 to 31 if we were in GCQ or MECQ, and for different levels of health capacity, meaning the capacity to treat, trace, and isolate COVID-infected individuals. So from 19% or 1 in 5 to 33% or 1 in 3. So what were the results that we were able to get? So on the left side, and thanks especially to the team of Doc Elvira de Lara-Tuprio for really looking into this, we find that over the course of the month, really there's a steady decrease in terms of case projection, but with dramatic around 48,000 less cases when it comes from GCQ at 19% to MECQ for 19%. And however, if we were to adopt higher health capacity, there would also be an appreciable decrease, especially in the case of GCQ. A very significant decrease, especially in deaths, which were from 6,800 to around 4,300. However, very important to keep in mind the cost of GCQ versus MECQ. And what do we find over here? To have a GCQ in NCR for 1 month would entail around 663,000 displaced workers, or a cost to the economy of 3.9 billion pesos a day. However, MECQ would nearly have double. You'd have 1.125 million displaced workers and a cost to the economy of roughly around 6 billion pesos a day for the economy. So how did the cost to the livelihoods of these workers versus the health costs and the value of statistical lives lost of those who are infected with COVID-19, how do those stack up? So that's what you find on the right chart over here. So it turns out, in terms of the cost of treating the infected, that cost is not that expensive compared to the rest of the costs that I'll be sharing with you. That's what we see in the blue bar over here. If you take a look at the cost of personnel, apparel, and beds, it's even smaller. You can see that small, narrow line. If you look at the long-term socioeconomic costs, they are quite significant, especially in terms of the GCQ. So this is the cost from those who suffer premature death and disability because of COVID. But if you stack that up to the immediate cost of those who are not able to go to work, it turns out that this is much more pronounced in terms of MECQ in that particular case. So what's the story that we're finding over here? If we want to take a look, while saving lives remains the priority, in terms of dampening the cost of the economy, what we find is that the key measure that needs to be taken to reduce the total socioeconomic cost to everyone, to minimize that overall, is to really improve the testing and isolation facility. Because GCQ at 33% has the lowest scenario, the lowest cost for all of them over the month of August. So These were some of the recommendations that stemmed from this exercise. If we want to overcome the saving lives and economy trade-off, what we really need to do is to improve our testing and isolation capacity from 1 in 5 or 19% to around 33% or 1 in 3, if not better. And along with UNDP, we were pushing the following recommended levels for all these different components of testing and isolation to help us achieve these kind of goals. So theoretically, we are doing around 25 to 30 tests a day at the time we did the analysis. But theoretically, we have the capacity to undertake 60 to 80,000 tests a day. Contact tracing has experienced a lot of attention, and we are recommending that we need to achieve a minimum, ideally better, 2 in 5 contact tracing efficiency. For isolation facilities, we may need up to 190,000 beds. That includes what's already been developed by government in the past few months. For suspected cases, up to 43,000 beds for mild cases, 9,000 beds for severe cases, and 2,320 beds for critical cases. And beyond this, there's also a lot of a lot of advances which need to be made in terms of broader and more consistent private sector, academia, and health sector participation in the IATF. We also need to improve our social protection systems and data governance. If you'd like to see more of our specific recommendations over here, please get in touch with me. I'd be very glad to share with you our policy brief, so you can take a look at the details of what we're recommending. So this is the presentation, but I wanted to leave one very last note on this. As in all models in economics, all economic models are wrong, but sometimes some are useful. And this was mentioned by a statistician at the 20th. Hopefully, the models which we put forward, they're not perfect. There are a lot of assumptions that need to be made, but hopefully, we hope that this can help provide some guidance to everyone in navigating the COVID pandemic, as well as our policymakers, who are as well as our frontliners leading the charge in our response to the pandemic. Thank you very much.
Eric, please stay on for the Q&A. Okay, so we will now open the floor for questions. Please feel free to type in your questions in the chat box, and I will begin by answering some of the questions. So first, okay, yes, for those who wish to have access to FASTER, so FASTER is designed for local government units and government agencies. So if you are members of these agencies, you feel free to register. Ken will type in the URL so that you can register, and then our team will get in touch with you for further inquiries. No? There are different ways of accessing FASTER. Ideally, it really depends on where your office is. So if you are at the regional level, you will have access at the regional level. If you are from the province, you will have access at the provincial level. And if you are part of an LGU, or a city or a municipality, then you will have access to city and municipality level. Okay. For the question on strategies for school opening, maybe we can leave that unanswered for this morning's, for this session. But after the session on age-structured model, we will get back to that and see what insights we can gain from the presentation of our partners. Okay. So Doc LV, there's a question directed to you. May I know what region the data was taken from? As indicated, the number of testing per day was decreasing. Do you have, maybe you can explain again to our participants why we were able to arrive at these numbers? Doc LV?
Yes, Rina. That was actually just a sample that was for NCR, and the data was generated last August 10 pa, so malayo na yun. With the assumption there that delta S is 25%, which is higher than the baseline of 19%. Okay. Know that with higher delta S or HSC parameter, the projections of future number of cases tend to be lower. Kaya nga sinasabi namin, we have to increase the HSC parameter in order to quote-unquote flatten the curve. So kaya po siguro nakita natin na medyo bumababa. It's because of yun, kumukonti yung number of cases. But again, that was last August 10 pa po.
Okay, thank you, Doc Elvie. So for the question, if the modeling can be performed at the regional or provincial or city level, yes po. So in the FASTER dashboard, we don't just have a single model for the entire country. If you want to know how many models we have, you simply need to count the number of cities, municipalities, and then level it up to provinces, and then level it up to regions. So ganun po karami yung models or yung code, no, na gine-generate po ng FASTER every day, no. So yes po, the model can be applied at the local level, which is actually the purpose of why we decided to use compartmental modeling. Okay. For the question on, how would you account to those COVID-19 patients that are not confined in the hospital and just died at home? Okay, for us to incorporate information on this one, of course, before it gets into the model, we would need to have access to this type of information, no? So unless it is reported properly through the systems where FASTER gets its information, we will not be able to account for this information. So as has been mentioned by several of our speakers, no, our model is not a perfect model, no? But it has been very useful. No? So we do consider and we do take note of the incompleteness, no, of the model because of the information that cannot be extracted right now, primarily because it's not being reported. But we do take note of it, and then so this is a work in progress, no, until we are over with this epidemic. That we will constantly improve and update and add more models in the FASTER dashboard. Okay, Doc Raymond, can you update us on the global efforts in the development of the vaccine for COVID-19?
Thank you, Dr. Rina. In terms of the global efforts, there was a recently released information from the World Health Organization's website. So currently, we have 172 countries and at least multiple candidate vaccines that are part of the COVAX initiative. Yung COVAX initiative po, it's a global initiative that's aimed at working with the different vaccine manufacturers to provide the different countries worldwide equitable access to safe and effective vaccines, at least kapag na-license na po ito at na-aprobahan. COVAX is co-led by the Coalition for Epidemic Preparedness Innovations, Gavi, which has been really stalwart in terms of pushing for vaccines, as a vaccine alliance, and also the World Health Organization. There are 9 CEPI or the Coalition for Epidemic Preparedness Innovations po na supported vaccines and na candidates, and 2 of those candidate vaccines are already in phase 3 clinical trials. These are from Moderna, from the United States po, and then from AstraZeneca, Oxford, that collaboration from Great Britain and Northern Ireland.
Thank you, Doc Raymond. Meron ba tayong timeline dito? Kailan po ba darating ang vaccine dito sa Pilipinas? Ano ang estimate nyo?
So for the vaccine, I think so the DOST Philippine Council for Health Research and Development, it's part of the global initiative for the COVAX, for us to be able to get access to the vaccines that have been licensed and approved. Once licensed and approved in a particular country, our own FDA will also do its own vetting process and approval process. Current estimates po, at the earliest we will be able to see probably in the Philippines will be 2nd to 3rd quarter of next year for the earliest available vaccine, and that will probably be either from the Moderna or the AstraZeneca Oxford vaccines. For those that are asking about the Sputnik 5 vaccine from Russia, I think the government has already express interest in terms of participating in phase 3 clinical trials, but I think there's still a lot more evidence that we need to see in terms of the realities and how far along Sputnik 5 really is in terms of vaccine development.
Thank you, Doc Raymond. No? So based on that information, siguro we will have about a year and a half to go. No? So maybe as an initial answer to the question on school opening, so maybe it will be a year and a half from now, mas safer po, no? Kasi syempre, di-distribute pa po yung vaccine, no?
And to that note, Dr. Rina, I think that's also to those who are watching, lalo na po yung mga magulang, I think please also prepare our mindset po in terms of having an online learning platform or familiarity on the different online learning platforms po, not just for for the year, kasi po lahat po ng mga nakakausap po namin, they are really just preparing na up until December lang po ang online learning platform. I think it will be prudent for us, let's be prudent enough po that to prepare for at least up until next year that our children po will still be undergoing or will be learning through all of these online portals po.
Thank you, Doc Raymond. Okay, so again, no, i-repeat ko lang po, for the recommendation that FASTER would be more useful, especially for planning purposes, yun po talaga ang isa sa mga motivation behind FASTER. It is really, was really designed, no, for our government agencies, no, to help in the planning. Please do register po at the URL https://faster.ehealth.ph/COVID-19 to access FASTER. And then now we will get in touch with you for details regarding your use of FASTER. And so if you register today versus if you register tomorrow, you will notice a difference. But that is a spoiler alert, no? We will be changing the look and feel of FASTER, no? Beginning tomorrow as part of the as an ending to our conference po. Okay, Doc Marie, may tanong po sa inyo. May I know what classification algorithm is being used by the police, no, to classify crime? Paano po ba natin na-classify yung major crime and minor crimes? Ano po ang basis nito, Doc?
We have this index crime and non-index crime. Some of the atrocities are more on the index crime, Ma'am Rina, and yung mga milder are put on the non-index crime, which is environmental on origin. And if we compute them, the aggregate score will be minor plus twice the major, then divide into 3. The assumption is that major crimes are twice as serious as minor crimes.
Okay, so maganda pong, very simple assumption, no? Okay, Doc Elvie, did you want to add more to it? Ano yung ating simple computation po?
Yes. Again, the classification of crimes into 2, major crimes and minor crimes, is determined by the PNP. Sila Doc Marie. Okay. For the scoring method, the FASTER team helped Doc Marie and the other PNP partners. The method is simple. There's no complex algorithm used. The number of crimes per indicator per LGU is converted into number per million population para comparable. No? Then a score is assigned based on a scoring range determined also by Doc Marie's team. And the scores over all indicators are added to obtain the final score and the corresponding risk indicator for the LGU. Okay. Over, Rina.
Okay, thank you, Doc Elvie. Let's go to the economic side naman. Jeric, are you ready now? There are several questions here.
Yeah, go.
Okay, so first, what possible sustainable program can be used to address to balance, no, the health and this is the major question, to balance health and economics, no, of the country. Siguro mga suggested programs, sustainable programs.
Right. I think like the very first thing which needs to be kept in mind is we need massive investments for improving our testing, isolation, and treatment capacity. especially because if you look at it from an economic point of view, having your employees get sick from COVID-19 is a major investment business risk, really. So we need to establish those systems. It's really the only long-term sustainable way to be able to go back as close as possible to what we had in the past. So at the very core of it, we need that kind of investment. I would argue, in terms of the details, there certainly we need to take into account available resources, but I think government should be prepared to spend upwards of 40 billion or more easily in terms of testing, isolation, and treatment capacity, if not more. So those are some of the initial computations that we've done. We looked at it, maybe to reach around 33%. It might cost, still very preliminary. It's around 42 billion pesos. That's our estimate for NCR. For the rest of the country, it might be a little bit more. Now, the other thing in terms of transitioning the economy sustainably, and this is part of the work which has been done by the economics department in the new normal, we will certainly need to think about new drivers of growth and employment. I think this will be connected somewhat to the FASTER model, and we are trying to account for these critical growth sectors. But if you look, for example, at the second quarter GDP data, what were the sectors that grew? The economy contracted by 16.5%. And there were only three sectors that grew: agriculture, information, digital, and finally, finance. Of all of those three, the only one with capacity for mass employment generation is really agriculture. So we need to find a way to invest substantially as well in agriculture, which makes sense because agriculture does not have the same kind of density. But certainly we also need to provide some kind of support to the sectors which are already there, because we need to find ways to stem the job losses which are emerging in many different sectors of the economy. So especially on the agriculture and the digital side, this is something that we want to integrate as well into the recovery feature of the FASTER portal by looking at the local agricultural capacity across different LGUs across the country, as well as the ICT preparedness when it comes to different LGUs. So different elements that you want to look and based on that program. But going back to my first point, if you cannot test, isolate, and treat, then that business risk will always be there. It's the only sustainable way to go back to a recovery program. Otherwise, the pandemic will always throw us back into community quarantine mode, which is extremely damaging for all of us.
Okay, wonderful. So there's a recommendation here to Dr. Cruz. This data are so interesting and beneficial. How nice if we could have nationwide data so LGUs and other regions could take measures not only on saving lives, but also on improving people's financial capacity. So maybe to answer that, now we are preparing a special page for the socioeconomic portal. We are just doing some finishing touches, and hopefully we will launch it soon, no? And we will invite our users to also attend that session. Okay, Jeric, may tanong dito, no? Do our models or do your computations show the effect of Bayanihan 1 and 2 to the economy?
Right. I think this goes out beyond the FASTER portal itself, but it is part of the work which the economics department has been doing. And we do have the working group which has been doing these computations, does have the capacity to be able to analyze that. One thing which we have been doing as part of our FASTER work, we will probably not be able to feature it live on the portal. But if you want simple computations of Bayanihan 1 or 2, say stimulus spending, the easiest way to go about that is to use something in economics that we call input-output analysis. So we were able to compute regional. In the past, we only had like regional input-output tables. We've developed regional level input-output tables. So we're able to do that now. The one thing which is really constraining us in terms of really refining it is that we need to go to the Philippine Statistics Authority to be able to get all the critical kinds of data and use the raw data sets. But the problem is when we were scheduled to go to PSA, and parang nagka-outbreak sa Eton Centris sa area nila. So we had to find, we're also affected by the risks also. if we want to go at the deeper level, this lies outside, and we do have people which are looking into this. And probably we will release the results eventually in a series of policy briefs. We do have the capacity to model using computable general equilibrium analysis. The way to think about this is you need to think some government spends, so it goes to businesses, then businesses will spend on their employees, then their employees will spend on consumption. So it becomes a big cycle. And how do you model all of that? So that's what CGE analysis is able to do. So we can easily plug in numbers for, say, biennium to be able to come up with that. But I would say CGE is a relatively complex endeavor. It might be better to keep it outside the portal, but we're always happy to help provide and link up with requests to the FASTER portal if necessary. Oh, and I wanted to give one last thing. In terms of the recommendations, going down to the sub-national and local level has been something that we have really been trying to do. It just turns out that getting data and estimates for the national level is easier than the local level because of data constraints. So hopefully we hope to come up with as much as possible down to the municipal level if possible. But we're constrained with what surveys and census and administrative data from the government level down to the LG level affords us. But hopefully we'll experience some breakthroughs, and as Dr. Rina said, we will be uploading and making the socioeconomic portal live as soon as we fix up some of the data things that need to be ironed out.
Yes. Okay, thank you. Okay, we now have 10 more minutes, only actually 8 minutes before the end of the first session for this morning. Let me run through the list of questions here and try to answer some of them. So the estimates for community isolation capacity, can we also consider those who may have a need for isolation but may not be COVID positive, especially with LSI and domestic travelers? Yes po, no, as mentioned by Doc Raymond, no, I think ang ating mindset dapat is we have it so that we should, as much as we can, isolate ourselves from the public, no? This means really to do self-quarantine if there's no need to go out. That's our first step in isolation. Second, if we have the symptoms and we feel that we do have it, kindly isolate yourself, but then report to your LGU, no, your symptoms, no. So alisin po natin yung fear na tayo po ay may kasalanan pag tayo ay may COVID-19, ano, kailangan po natin siyang i-report para po tayo ay maabisuhan so that they can give us guidance, no, on how to proceed, no, where to do the testing, and then if they see that your home naman is okay for isolation, that you have your own room and bathroom separate from the family, I think it will be okay. But I think the government now is focusing on providing us with better isolation facilities, no, to encourage people not to hide, no, from reporting. And so if you are not COVID positive, and it is okay also to isolate yourself, no, because it might be another disease that could be infectious also. Can academic researchers be given access to FASTER? Opo, yes po. So again, no, please do register. There are a lot of participants who register day in and day out, no. So minsan hindi po namin na-monitor. Feel free to email us, no, pag hindi namin nakita yung inyong initial registration request. For researchers, may follow-through po yan, yung purpose po ng pag-research, and then we course it through our Epi Bureau. Kasi usually po, may hinihingi pong data set, no, yung mga researchers. What we do is we actually give them the data set in the format that they need for their research, no. So yes po, FASTER is accessible to academic researchers, to our students po, no, who want to maybe use our projections for their studies po. Okay, can FASTER integrate automated tracking tools in contact tracing, no? So yes po, there are initiatives under the DICT governance po for FASTER to be integrated, no? So ang FASTER po ay nasa dulo, no, nung lahat ng listahan ng ICT systems, meaning FASTER is the recipient of all the information coming from different systems, no? Mula po sa citizen reporting, sa hospital reporting po, sa lab reporting, sa COVID-Kaya information system, lahat po yan, and then pinifeed po yan sa FASTER at dun po namin ginagawa lahat ng analytical tools and models, no? So for contact tracing, meron po tayong special presentation tomorrow kung ano po yung talagang directly nakakonect na po kay FASTER. So for the LGUs who are here, if you want a direct model from contact tracing in your FASTER dashboard, you may want to opt to use Tanod COVID contra COVID contact tracing app po. But the other contact tracing apps, as long as it is approved by the ICT governance group, kinoconnect na po siya sa DOH COVID-Kaya, and then from there po, i-feed na po siya sa FASTER. Okay. Okay, ano po ba? So we have 4 more minutes. With limited funds, what strategy would have the greatest impact in reducing the transmission? So again po, ang recommendation ng aming model at nag-agree naman po ang maraming experts, no, na isolation, no, ang ating priority now, no, because meron po tayong limitation sa ating testing capacity. Ang importante po ay as a citizen, no, pag may naramdaman na po tayong symptoms, ay mag-isolate, and then tsaka po tayo mag-inform sa ating government, LGUs, para po mabigyan tayo ng opportunity, malaman natin kung saan ang ating testing facility, and maalagaan po tayo kung kailangan. Okay, maybe the last question before we end the session, and I will let the head of the mathematical modeling team of FASTER answer this. UP makes the headlines regarding their projections about COVID. How do the quantitative results of FASTER compare with the output of the UP COVID task force? If there are comparable studies on epidemiological, health requirements, risk, and socioeconomic costs. Doc Elvie, what is our response to this inquiry?
As I've said before, we should not be comparing models. The output of a model is based on assumptions, okay, limiting assumptions, as well as the purpose of the model. Okay, so if the model has a particular use, then okay siya, no? So in fact, we might need more than one model in order to address a given problem. So instead of comparing the results of different models, which might not be feasible in many cases, we should be looking at this available models as giving different insights to a particular problem. So parang iba-iba yung tulong ng bawat model na yon. Okay.
Okay,
So
thank you, Doc Elvie.
Yes.
Okay. Thank you, Doc Elvie. Andre, that ends our Q&A for this
Yes.
first session.
Okay. Thank you, Doc Rina, Ma'am Elvie, and all the speakers of the first session. No, we have a 2-minute break. By 10:40, I'll be talking again and we'll resume the session. Ay, actually 1 minute pala kasi ang dami ko na sinabi.
Gawin mo ng 5,
In 1
Andre.
minute.
Gawin mo ng 5, Andre.
Sige, 5 na. Para totoo na yung break.
10:45 tayo.
Yes, 10:45 will be the resuming of the second session of the morning. Sige. Bawal po umalis, everyone. Salamat.
Salamat po.
Good morning again, everyone. As promised, 10:45, sada sulit yung break sa inyo. Thank you again for all the speakers of the first session this morning. Now on to the second half of day 2 of our 3-day event. I now call back Doc Elvie to open the second session for the morning. Hello, ma'am.
Hi, Andre. Okay, thank you very much. Good morning, everyone. Allow me to introduce our next speaker. Associate Professor James Trauer is head of the Epidemiological Modeling Unit at Monash University's School of Public Health and Preventive Medicine. Dr. James is a practicing respiratory and public health physician who attained his PhD in mathematical modeling of infectious diseases from the University of Melbourne in 2016. Since then, his team has been primarily engaged with modeling TB control to support the Global Fund to fight AIDS, TB, and malaria, and to support the WHO, but has currently pivoted to support the global fight against COVID-19. So let us all welcome Dr. James Trauer. Good morning, Dr. James.
Hi, Elvie. Thanks so much for that introduction. So I'll just see if I can share my screen. I can hopefully take over sharing from you. So have I done that correctly and everybody can hear me okay? I have reasonable sound?
Yes, Dr. James.
Great, thank you so much. So thanks so much for the opportunity to speak. I believe I'll be speaking for about 20, 30 minutes, and then I'll hand over to Jamie Caldwell, who I've been working closely with on this application to the Philippines. It's been a really wonderful experience working with the Philippines, as much as it's been a very difficult situation fighting the pandemic and understanding the epidemiology, and it's certainly been a huge challenge given how rapidly everything's been changing. So we have been working to support the WHO, Western Pacific Regional Office, to support the Philippines and Malaysia in modelling COVID control. And in relation to the Philippines, we've been working with the Interagency Task Force and Ateneo University and a number of other groups. And we hope that the model that we've built has complemented some of the other activities that have been undertaken. At the end of the last session, I heard some questions around different models being appropriate for different questions, and certainly that we would agree with that, and we've built a model that we hope complements some of the other ones that are around, and there are certainly many different ways of modelling COVID-19. So we're going to talk about, Jamie and I will talk about the application of the model to the Philippines epidemic, the particular challenges that we've faced in building the sort of model that we've been using, and the challenges around interpreting local data and incorporating them into one overarching modelling framework. So basically at its most fundamental level, the model that we've been using is an SEIR model. And I know that there's many academics on the line and many of you will be familiar with this, but of course, the reason to choose this particular model is because it's a mechanistic framework. So it captures explicitly the mechanisms by which infection transmits and by which individuals transition through various compartments. Of course, many of you will know that SEIR stands for susceptible, exposed, infectious, removed, and people are explicitly considered to move through those compartments, and that's the framework that we've adopted. It's a fascinating framework. I think it was proposed in 1927 in a seminal paper that's been cited a lot since then by Cormack and McKendrick. And it's a very simple framework. It only consists of 4 compartments, and yet it can capture a huge amount of information within that incredibly, apparently very simplistic structure. So in particular, you have a bell-shaped curve, and if you allow an epidemic to play out without any sort of mitigation or any sort of public health response to stop it from playing out, this is indeed what we see in reality. And for perhaps milder pandemics, or in the case of influenza in 2009, we indeed saw a number of bell-shaped curves because we either weren't able to or didn't put in place such severe restrictions as have been applied for COVID. And you can see under that framework that we have an exponential growth phase at the start. At this point, if one person is introduced into a fully susceptible population, they will infect a number of secondary people who, which is determined by the R0 at the point that everybody's susceptible and we're not implementing any interventions. So the model quite clearly demonstrates that. It also demonstrates that the herd immunity threshold is reached at the peak of the bell curve at the very top. So as you're on your way down the back of the slope of the bell curve, you're actually going past herd immunity and developing additional immunity from what you would require to stop the virus transmitting. And as you get towards the bottom, the susceptibles are depleted, but they don't go down to zero. As the susceptible pool drops to the point that people can't continue to be infected, the transmission rate falls and the epidemic dies out. But it's never the case, even with a very high R0, that all of the population is infected. And these sort of messages were first conveyed by some early models that were only a few months ago, but they were early in the year and early in the pandemic, that were first put together by the Imperial College Group. And this one was very widely cited and was produced by ''𝗎𝘃𝗁, who's one of the senior members of the Imperial College Group, who developed an agent-based simulation. So agent-based models are stochastic. They're quite different, certainly in terms of the engine that drives them underneath the surface from the SEIR framework that I've just presented. And yet at the same time, often it's a group of individuals that are progressing through those states from S to E to I to R. And so this agent-based framework showed that under an unmitigated situation, you'd have a very large epidemic playing out. And it may not be well illustrated on that particular slide, but you can see here that if we consider the number of people admitted to hospital as the bell-shaped curves here, and if you look at hospital capacity in places like the US and the UK, the peak of the bell-shaped curve is just so far above hospital capacity that these early models were very useful in explaining to everybody and alerting to everybody how severe the pandemic might be. We've also been able to show this with very simple models, which is not the one that we've been applying in the case of the Philippines. But in order to create a compartmental structure that can capture this, you just need to take the base SEIR model. You might replicate some of the compartments, but you need to have some way in which you can include people who are admitted to hospital and people who are admitted to ICU in that, to try to link that quantity to the other compartments in the model. And we got similar results. So this is just an illustration of how a much simpler model can convey the same messages, that in a place like Australia now, that even, so under an unmitigated epidemic, which is the top panel, the left curve, we still have that brown line, which is the ICU capacity, going way above ICU capacity in Australia, which is the horizontal blue line. And really, until you get to the bottom panel where you push the effective reproduction number below 1, you still have major problems and significant epidemics. And the flip side of that is that under the situation of an unmitigated epidemic, we have this black curve, the solid black line, which shows the number of susceptible people in Australia, as an example, being depleted. And as that epidemic plays out, you cross over the herd immunity threshold and have more of the population exposed and infected than you would want in order to protect yourself from future epidemics. And you end up down towards the bottom of the screen. However, if you do get the R effective number below 1 and you, for example, get it to 0.8, then you have the sort of dash dotted line, which is right up at the very top, and you basically end up with none of your population being exposed. And so you remain highly susceptible to recurrent outbreaks. And so that is the fundamental epidemiological and modeling question and problem that we've been facing in all over the world, including Australia and the Philippines at this point. And if we compare this to, if we think about this in the context of pre-pandemic planning, so we can see that there are a few options. We can either look towards elimination, where we keep the R effective number below 1 and try to keep case numbers down to almost 0. So New Zealand, for example, has been very successful in that, and Vietnam and a number of other countries have managed to have very, very low transmission. But prior to the pandemic this year, the plan was always to head for mitigation. And that's evolved incredibly rapidly. I think even 6 months ago, we were still thinking in terms of mitigation as our major strategy. And the reason for that is that as pandemics played out through the course of the 20th century, we seem to have this march towards pandemics becoming steadily less severe and less transmissible. So the last one that was probably perhaps as bad as COVID-19 was in 1918. So obviously that's not something that anybody who's alive today can remember. And as the 20th century played out, we had some pretty significant pandemics through the middle of the 20th century, but the ones towards the end of the 20th century into the 21st century were generally milder and less severe. So the plans that we had for a pandemic when it arose were built around mitigation. We assumed we were going to be able to allow some transmission and mitigate that in some way, but still allow significant community transmission. And so all of this background informs the way in which we built a model to be applicable to Philippines. It's basically an SEIR framework, but we wanted to elaborate that framework in a couple of ways. And so we did a couple of things. We, first of all, from the basic SEIR model, we split the E compartment into two and the I compartment into two. So the reason for that is that we've allowed the coloured red boxes to be more infectious. So we've allowed for the fact that people can be infectious before the point at which they develop symptoms, which is generally what we mean by the point at which they enter the I compartment. And we've also allowed for strategies in which people can have their infectiousness reduced as they progress through their symptomatic period and go from the first to the second I compartment. So that's the basic model. And so the reason why we chose to have that second E compartment be significantly infectious comes from papers like this one that was published in Nature Medicine and was a study that was done in a couple of different hospitals in southern China. And they used two different data sets, one of which I won't go into in a lot of detail, but you can see that they had information on primary cases with COVID and the secondary cases whom they had infected, which is the so each case is a horizontal row of this diagram, and the point at which the primary case got symptoms is the red dot, and then their secondary got symptoms at the point of the blue dot, and we know the window, the horizontal green bar, during which those two people were exposed. So these researchers were able to make some inferences about the timing of infectiousness relative to the timing of symptoms. They could do that from this data set, which is sort of a public health data set, but then they could also do it from this second data set that I've put on the screen now, which shows the cycle time. So a low CT value means more virus being produced. And so the higher up that vertical axis you go, the more virus there is. And the horizontal axis here is the number of days from symptom onset. So what this is basically trying to show is that from the point at which we start measuring virus secretion, we already are seeing a decline in the number of virus particles that are being produced. So, so as you can see here, the data is a bit sparse at day 0, but day 0 is the point of symptom onset. And already that appears to be the peak point of virus secretion. And it's also the point at which we start observation. So the inference that these researchers made, what they thought they could get out of this information is that the peak of transmission is actually before the symptoms start in a lot of cases. So they could make this one conclusion from these two data sets. And if you look at this in a sort of a cartoon fashion, or this is the way they sort of drew it in the case of COVID, COVID is probably something like the top left panel here, where we have an incubation period, which is the light blue bar, and then they move into a symptomatic period, which is the sort of purple or mauve bar. And the distribution of infectiousness, being the blue bell shape, is sort of straddles across the point of symptom onset. So they could make this inference from those two data sets, and they illustrate it in this way that we have significant transmission prior to the point at which symptoms begin. And that's the case for COVID. And it's probably one of the major reasons why it's distinct from SARS 2003, is because in that case, the symptom tended to begin sometime after symptoms started. So there was a window period in which people could be identified, isolation could be put in place before infectiousness had started. And that just made the public health response so much more effective, but it's a much more difficult undertaking in the case of COVID to really identify those people before they become infectious and cut them out of the epidemic. Influenza is somewhere probably in between the two, as indicated by the bottom right-hand panel, but fortunately the last few influenza pandemics we've had have not been as severe in terms of mortality. So we wanted to capture some of these effects as well. So we split our model into a number of different groups, which I'll talk about in just a moment. But in particular, we wanted to split out the group who were asymptomatic and consider that they were likely to be less infectious, but then also have this pre-symptomatic group, which is the sort of the second column and the first of the coloured columns, which we considered to be just as infectious as people in the early phase of their disease. And then as they progress through to this later phase, in the event that they're detected, we assume that they can then be isolated or quarantined in some way and their infectiousness can be reduced. And we also assume that that would happen to hospitalised and intensive care admitted patients. So that was how we chose to stratify our model when we got to the point of the I compartment. And so we also wanted to have some way of simulating that a proportion of people would be detected and a proportion of people would not be detected. We considered that the asymptomatic people could not be. And then of the ambulatory community living people, who are the second and third groups here, a proportion of them marked ambulatory were never detected, a proportion of them were detected. And then a bit like I showed in that simpler model, we also wanted to capture explicitly a group of people who were admitted to hospital and a group of people who were admitted to ICU. So just to summarize that, the bottom four groups are the symptomatic ever detected. The bottom three are the ones, the bottom four groups are the ones who ever have symptoms. The bottom three groups are the ones who are ever detected. The bottom two are the ones who are hospitalized, and the bottom one are admitted to ICU. So that was just a choice we made around model construction, but allowed us to mechanistically simulate a number of processes, including capturing local hospitalization and ICU admission rates. In terms of the rate of detection, we wanted to have something that varied with time because we believed that to be pretty important, particularly early in the epidemic. And so we had a time variant function that we have previously been setting with some fairly arbitrary parameters, but we just wanted to have some way of incorporating into the model that detection was relatively low right at the start of the year in sort of January, February, March time. There wasn't a great deal of testing capacity in many of these countries, including the Philippines, and that increased to much higher rates. This is actually the proportion of symptomatic people who are detected, because I mentioned that asymptomatic people can't be detected in this model. So we thought that was really important, particularly if you're trying to estimate the size of the epidemic from data like notifications, because this paper from the London School CMMID group just gives a pretty good illustration, I think, of how extreme the variations are in terms of case detection. Fortunately, I live in Australia, although I live in Melbourne, so it hasn't done me that much good. That we've had very good testing capacity, and this group, this study estimated that we were detecting in Australia, certainly during our first wave, a large proportion of all symptomatic cases. Whereas at the other end of the scale, we have countries like France and the United Kingdom, where only a handful of the total cases are detected. So that has major implications for how you design a model. And I think it's necessary to make some sort of assumptions around this. And so we incorporated it into our model, along with some assumptions to try to locally contextualize it to the Philippines. Other groups have done sort of similar things, and this was a paper that was published in Science by Simon Cochemet's group, and they were able to construct pretty good curves that looked very much like the epidemic that played out in terms of the hospital beds used and the ICU capacity, and the proportion infected after the epidemic looked pretty similar to what came from serosurveys. But much like many other settings around the world, probably including the Philippines, there was a need to make a lot of assumptions around exactly how much transmission and infection there was, because in France, outside of those admitted to hospitals and ICUs, there was pretty limited testing capacity, and the CMMID group at that time were estimating sort of 4 to 5% of all symptomatic cases were being detected. So just calibrating a model to notifications on the assumption that all infections end up as a notification is, in the case of France, certainly a very dangerous thing to do. So the other thing we've done to make our model a little bit more complex, and we tried to avoid complexity to some extent, but we have felt it really important to include an age stratification within our model. And that's for a number of reasons. Certainly COVID plays out very differently in different age groups. And so that influences how you might go about responding to and mitigating the epidemic. And it influences a lot of the parameters that you might want to put into a model. So I think that's a distinction between our model and several other SEIR frameworks that are around. I wouldn't like to comment on every model that's being put in place in the Philippines, but it's that's one thing that we think that our model brings to the table that others may not. And so one of the reasons, so there's several reasons why we might want to include age structure in our model. Perhaps one of the most important is that we know that children are less likely to become symptomatic. Well, we believe that children are less likely to become symptomatic given an infection, which the CMMID group refer to as the clinical fraction. We also believe that children are less susceptible to infection, which means that given the same exposure to COVID, they are less likely to become infected. The probability of hospitalization is probably quite age-related. It's perhaps not as important as the first two, but it appears to vary by age. And the infection fatality rate, which is the probability of death given that you've been infected, is extremely influenced by age. And so we were very keen to put that in. And we also know that age patterns are very different mixing patterns are very different by both age, and they're also quite different by setting. So we wanted to have some Philippines-specific mixing patterns that we could implement into the model. So we included them as well. The parameters that we use for capturing some of those things are here. You can see that our clinical fraction is considerably lower in the younger age groups. You can see that the susceptibility is lower in the youngest two age groups. This again comes from a CMMID paper. And the infection fatality rate is just dramatically different by age. This comes from serosurveillance data from Spain, in which we believe we have an estimate of the proportion of the population by age who were infected, and we know how many deaths occurred over a period of time by age group as well. And so we can estimate an infection fatality rate. And it's not quite zero, but it's pretty close for the youngest age groups. Whereas as you get towards 75 and above, we're estimating somewhere between sort of 5 and 10% infection fatality rate. So very, very highly age specific. And this, as I mentioned, it's quite important, I think, when you're building a model to capture the epidemic in the Philippines, because there's a very different age structure. So in addition to having a contact structure that was contextualized to the Philippines, we also have an age pyramid that's contextualized to the Philippines. And so the fact that there just are fewer people in the 75 and above age group is very significant. I mean, for example, if you compare Philippines to Japan, the proportion of people aged 75 and above is dramatically different between those two countries. I think it's sort of over 15% in Japan and I think probably below 5% in the Philippines. Sorry, I should remember the number. So the difficulties with case detection also influence the way in which we understand case fatality rate and infection fatality rate. And as you can imagine, when you see those case detection proportions varying so much, if your denominator is just diagnosed cases, it's very dangerous to assume that a case fatality rate is in any way representing the true infection fatality rate, which is the number of deaths per infection. In fact, even papers like that one that I presented from France, they try to estimate an infection fatality rate using different data, and they use data from the Diamond Princess. And you can see that this boat that had a number of cases on board, and they described the epidemic very well, tested just about everybody in the boat, and discovered that there were 712 infections out of 3,700 odd passengers. It's been used quite widely to estimate the infection fatality rate, and yet there were only 14 deaths and 4 long-term ICU admissions who were assumed to have poor outcomes out of those 712 cases. So in terms of thinking about how the epidemic's playing out in the Philippines in terms of deaths, which is one of the most important things to look at, as I mentioned, the model is one way to do it. Assume a universal infection fatality rate and apply it to other settings. And I believe in the Philippines, we don't have too many other ways to estimate this because we don't have, as far as I'm aware, universal data across the Philippines for cause of death that come in real time. So we don't have sort of vital registration systems that are of the standard that they are in countries like Europe and North America. And in those settings, in the vital registration systems in Europe and North America show considerable spikes in mortality, which are largely attributable to COVID. And also apparent spikes to some extent in non-COVID related mortality. So just looking at all-cause mortality and comparing between settings like this and developing countries where the vital registration systems may not be quite as strong is a way to validate the models that we're putting in place. And we would like to do that in the Philippines. We would hopefully work towards that in the near future. Countries like Indonesia don't have national vital registration systems, but the Jakarta has good records of burials and confirmed deaths, and so that's another way to look for these signals in terms of all-cause mortality. I might skip over a couple of slides because I think I've been going for 25 minutes and I want to hand over to Jamie fairly soon. So I've talked about most of how we've developed the model. So we also for the Philippines don't have age-structured mixing matrices that are based upon real survey data. They're quite hard. It sounds like they should be easy, but they're harder to do in practice than you might think. But fortunately, in 2017, synthetic mixing matrices were published for 152 countries, including the Philippines, that were published by 𝗤𝗄𝗄 Prem, again from the London School, who has recently updated these in a preprint for 177 countries, including the Philippines. And so we've been using these earlier ones, and we'll probably switch over to using the new ones once that preprint reaches publication. But they look pretty sensible to begin with. The overall age structure of the mixing, which we put into our model, can be disaggregated according to setting, or what Prem calls location, as work, school, or other locations, and home as well. And so when we apply these mixing structures to the Philippine-specific population, we hope that we get a bit of a better capture of what's going on with the local epidemic, particularly in terms of which contacts could be modified in some way to simulate an epidemic. These are the updated ones. In fact, there's not a huge difference from what I can see. Only the difference is perhaps the darkness of the color, but these are the 2017 ones, these are the 2020 ones. So we'll start using these later ones soon, and there's not that many differences between the two. The more recent ones, I believe, can be disaggregated according to rural and urban status, and they also use more updated data, but we would expect to get similar results once we do incorporate the new mixing structures. And so we use this structure to simulate the effects of non-pharmaceutical interventions. And it's to some extent crude, but at least it has that very, it's sort of data-driven in the sense of we can modify, so what we can do is we can modify the location in which contacts occur by scaling one of those mixing matrices. So for example, if we were asked the question, what would happen if schools were to go back in the Philippines, we would take one of these mixing matrices and crank back up the school-based contribution to the overall mixing matrix to simulate that into the future after calibrating the model, which is what Jamie was talking about. So that's one example. We can do that for workplaces as well. And to implement all of this, we need some sort of input data about how those mixing matrices have scaled over time. So we have functions of time which represent the extent to which people are going to schools and workplaces that are informed by Google mobility data. And Google mobility data is, again, imperfect, like all of the inputs to our model, but it has the advantage of being produced very, very regularly and in a fairly consistent format, so we can plug that into our model each week and get new results. And so with all of those things, we think we have a sort of a backdrop of a model that is pretty applicable to the Philippines. And we were hopeful that we were going to get some really good, sensible results out. And it's been a little harder than we anticipated. And Jamie will talk about some of those difficulties. But that was at least why we built the model in the way that we did. I'll hand over to Jamie.
Thank you very much, Dr. James. I'm sure the participants, mostly academicians, researchers, and those affiliated with different government agencies learned a lot from your talk. Okay. Our next speaker, let's move on to the next talk. Our next speaker is Dr. Jamie Caldwell. She is an ecologist and infectious disease modeler. Her research investigates ecological, climatological, and social factors that influence disease transmission and uses those relationships to develop predictive model for human and wildlife diseases. She is currently a postdoctoral researcher at the University of Hawaii at Manoa in the USA, and a visiting adjunct faculty at James Cook University in Australia. Prior to her current role, she was a postdoctoral fellow at Stanford University in the US. Dr. Caldwell received her PhD in 2017 from the University of Hawaii at Manoa. Dr. Jamie, the floor is now yours.
Thank you very much. Let me share my screen. There we go.
Yes, you're
okay, good. Great. So that was a great introduction from James. Thank you so much. I'll be talking today how we're applying this autumn COVID-19 model application to the Philippines. Some will be a little bit of a reiteration of the end of James's talk, so I'll try to go through that rather quickly and then focus on the results that we've been finding. So when we first began this project, and with a lot of help from all the people James mentioned in the beginning, especially from Ateneo University, we developed this for a national Philippines model, and we've continued to do that, but we quickly realized that the transmission as well as the response to transmission has been really heterogeneous. So we've moved forward with subnational models as well for the regions where there's the most transmission, including the National Capital Region, Calabarzon, and Central Visayas. And to really make this model Philippine specific, we use these synthetic contact matrices that James just spoke about. So this is looking at the contacts among different age groups with each other through time in different locations. And overlaid with that, so that's synthetic matrices for the whole country. But then within each region, we can take the population pyramid and look at the number of people in each age group underlying that. In addition, we have these Google mobility inputs, so we can look at how movement in different locations are changing through time and how different they are compared to pre-COVID levels. In addition to that, we know there's been really different response timelines to the coronavirus across the country and then within different regions. So in addition to these contact matrices, the Google mobility data, we've also introduced some micro distancing to account for different measures like the enhanced community quarantine. And so those are the key elements that we've adapted to the Philippines, as well as allowing a number of the parameters in the model to be fit, and then we can look at the posterior distributions to get an estimate around things that we can't measure directly, like the infection fatality rate and case detection rate. So once we have this model, well, it could tell us anything, and we really wanted to know that it's reproducing some patterns that we're seeing in real life. And this has turned out to be really challenging with the data that we've been using, which is daily notifications or confirmed cases, ICU occupancy, and deaths. And so after many iterations of the model, we've decided to only calibrate to notifications. And we're starting to get patterns that we feel more comfortable with. So this is just looking up until today using, well, actually yesterday, using calibration data up to about 2 weeks ago. And so on the graph on the right, we have the month on the x-axis and the number of people affected on the y-axis. And this yellow line is the model data, whereas those x's are the daily notifications from the COVID-19 tracker. And so what we're seeing as a 50th quantile value for the total cumulative cases as of yesterday is around 185,000 people, whereas the confirmed cases are 189,000. So it's quite similar to what we'd expect in the model. Similarly with deaths, we've predicted about 1,800, whereas confirmed deaths are close to 3,000. So we're underestimating deaths quite a bit, but the notifications of the cumulative cases are on track. When we look at the regional model for Metro Manila, we're similarly predicting 123,000 cases, where there's been 107,000 confirmed, and about 1,200 deaths and 1,400 confirmed. And those values fall right within the 50th percent quantile range. So we feel fairly confident that the model has at least been capturing the trajectory of the outbreak so far. Similarly, in 𝗪𝗪, our model is around 33,000 and the actual data is 27,000. And for deaths, we're extremely close, predicting 273 deaths, whereas there's been 250 confirmed. So for the national model, Metro Manila and 𝗪𝗪, we've been doing fairly well. In contrast, we've had quite a bit of difficulty fitting the data to Central Visayas that has this bimodal distribution where you have 2 peaks, with the second peak as a slightly bigger wave than the first one. Here, we're underestimating both cases and deaths quite substantially. So this is the region where I'd say we should have most caution with what I'll show you for the rest of the talk. So if we allow current conditions and restrictions to continue, what these models are telling us about current, I'm going to show a couple graphs that'll tell us what should be happening in terms of exposed, infectious, and pre-symptomatic cases throughout the whole population. So again, the y-axis has persons infected and the x is time. And right now, if these models are correct, what it's telling us is this black line is yesterday's date, where there's probably about 200,000 infectious people in the country. But the good news is, if this model is correct, it suggests that the peak is in about a week from now and not much higher infectious number of people in the population. Now, these results are a bit interesting because the Philippines model is smoothed over notifications essentially for the whole country, but it's really coming from key regions of the population. So when we look at Metro Manila, the results are a little bit different. So here, we're still showing that we're very close to what we expect the peak to be, but the total number of infectious people is quite higher. So what we're predicting just in the Metro Manila region is about 327,000, and expecting that to go up by about 4,000 in the next 2 weeks. The story in Calabar zone is quite a bit different. What our model is indicating is that about 60,000 people are currently infectious, but we're on the trajectory to go quite a bit higher with a peak happening in mid to late December at nearly 400,000 people. So this is very different from the model I just showed you for Metro Manila, where the cases are actually looking like they're going to go down by December. So that would potentially indicate a change in the hotspot of transmission. Now for Central Visayas, we see something similar with about 50,000 infectious people at the moment and on an upward trajectory where we'd expect the peak to occur on October 26th with nearly 200,000 people. Again, this is if current conditions continue, which we expect the government and people to respond as the epidemic change. And so this is what we actually think the autumn model framework is most valuable for, which is considering different scenarios. So what might happen if we choose to ease different restrictions? And so working with Ateneo University, we decided on 5 different scenarios that were of interest. The first S0 is our essentially no model that I just showed you, where current restrictions continue. Whereas we have 5 alternatives. Here we're saying people will return to work and school and different percentages on October 5th. So the first 2 scenarios, half the adult population would return to work and 25 or 50% of kids would return to school. Whereas in scenarios 3 through 5, we have 75% of adults returning to work, and then 25, 50, or 70% of kids returning to school. And I also should mention this has been an iterative process where we're updating every week and we can change these scenarios. So initially the scenarios were actually set for August 24th. And then when there were policy changes about keeping kids home from school for longer, we updated to October 5th. And I expect we'll continue to update these as more information comes through about what might happen with people returning to work and school. So what we can do with these scenarios is look at how they diverge from each other in the future. So essentially these orange lines are what I just showed you where current conditions continue. And then what would happen if you let more people back to work or school. And so for the entire Philippines model, we get something interesting for ICU beds needed, hospital beds needed, and notifications or confirmed cases, which is that if 50% of people return to work and 25 or 50% return to school, it seems like the bed use and notifications and hospital use can stay the same or still enter a downward trajectory. Whereas when we get to the 75% returning to work, we start to get a real uptick in all of those. So there's a bit of a break point between scenarios 1 and 2 and then 3 through 5. In contrast to that, for deaths, what we see is that we would expect a peak a little later than October, maybe mid-October, early November. And really across all the scenarios, it's just the magnitude, the total number of deaths that'll change, but the timing of that should be relatively consistent. In Metro Manila, we see a bit of a different story. If things continue, it looks like we're on this downward trajectory. And so regardless of how many people go back to work and school, we should still see cases and hospital use and ICU bed use going down. It's just the number needed at any point in time and how quickly you might go down to 0 or at least normal levels. For Calabarzon, it's a little similar to the national model where there's an increase and really the magnitude of increases dependent on what scenario you're looking at. And allowing 50% of adults back to school, back to work and 25% back to school or 50% back to school, keep the numbers quite a bit lower than if allowing a much larger proportion back to work and school. And then Central Visayas is, again, a bit more like Metro Manila, where we'll see a peak in mid to late October, maybe early November. And again, the trajectories are really similar. It's just the magnitude of response. And so these are some of the key results I wanted to highlight. And now I'd like to show you the website because there's a lot more you can look at and explore, and much more than I can really talk about in this session. So when you enter the first page, there's a description about all the different pages you can look at. And I'll walk you through a couple of the key ones. And then there's information about when the models were last refreshed. And also, if you really want to dig into the details of the model, you can go to the model runs and look at the posterior distributions for all the parameters and how the data fit to the calibration data. The models fit to the calibration data and all of those details. And so just to give you a look at maybe the first few pages, they're much more interactive. So you can actually move the dates around. You can look at the different scenarios. You can change the region. And if you hover over, you'll get exact values. What's really nice about this as well is everything's broken down by age group, so you can look specifically at certain age groups in certain locations under any of the scenarios given. I know we're running tight on time, so I just wanted to give you an overall introduction, but you can look at mortality projections, scenario projections, uncertainty in the data, more comparisons with the local data that we use for calibration and others that were collected but not used for calibration. And then you can also dig into those synthetic mixing matrices and the Google mobility data. So with that, I think I'll turn it over so we at least have some time for questions. I think that would probably be more useful than me continuing to go through the website. So thank you so much for inviting me to talk and allowing us to share some of the results we have as we continue to improve this model.
Thank you very much, Dr. Jamie. Okay, participants may now key in their questions. If you have questions about the model presented by Dr. James and Dr. Jamie.
While we're waiting, could I possibly just make one or two just tiny little clarifications? I just want to perhaps stress that the way we simulate workplace and school reopenings is a little different, because we assume that for workplaces, we get that from Google Mobility. So we assume that as you allow people to go back to work, that the mobility input to the model will head back up towards 100%. But there is no Google Mobility indicator for schools. So schools are at 0%. So in some ways, it's not a fair comparison. And I guess we saw sort of similar incremental changes for workplaces and schools reopening. But actually the schools, it's a much larger proportion of all the contacts that go back, because we assume they're 0. So a 50% increase goes from 0 to 50, whereas for workplaces, they're currently sitting, I'm not sure actually, somewhere around sort of 40 to 50% of baseline based on the Google Mobility. So they go up from that to sort of, what is it, like they go up from sort of 40 to 50 or something, Jamie, is that correct? Mm-hmm. Yeah. So it's just, I think it's sort of, just to say, it slightly overemphasizes the importance of schools in increasing the transmission as people go back, and maybe underestimates the importance of workplaces. And so I guess what we're showing from these models, now that we've got a reasonable calibration, appears to be that, yeah, Manila, because it's had such high case rates, a significant proportion of the population appear to be recovered. It is quite dependent, though, I think, upon what you assume in terms of your case detection rate, because we're assuming considerable amounts of community transmission, because we think that case detection rates have been incomplete, but it's hard to say how incomplete, I suppose. And so that, I guess we think that we're getting towards not herd immunity, but a point, because for a start, we already have the mobility rates decreased, but we're getting to a point at which there's substantial population immunity that's enough to hopefully do something to reduce transmission in Manila, but elsewhere in the country, there's still large proportions of the population susceptible, so we would expect continued growth in the epidemic. So sorry, I didn't mean to I hope I didn't contradict anything there. I totally agree with everything Jamie said. I just wanted to add those couple of tiny clarifications.
Okay, thank you very much, Dr. James. Let me add, by the way, some of you might be asking, the model of Dr. James and Dr. Jamie is also under an SCIR framework, okay? Although the FASTER model is also SCIR framework, we have limitations in the sense that we are not able to do an age stratification. So we don't divide the population according to age, whereas the model presented by Dr. James and Dr. Jamie includes age structure, the age stratification, and they are able to do so using mixing patterns obtained from a study and Google mobility data. Okay, so thank you very much. By the way, the model presented can also be found, can be accessed through the FASTER dashboard. And I think Dr. Jamie also sent to us, showed us the link, okay? It's accessible, Dr. Jamie, right?
Yes.
Even outside the FASTER dashboard. Okay, there are some questions here. Number one, was age stratification in viral load or shedding considered or ruled out? So was age stratification, okay.
Yeah, that sounds like a question for me. Yeah, so the answer is pretty much yes. I mean, so we had a clinical fraction, which we, as I mentioned, we got from the CMMID work, which is the proportion of people who are symptomatic if they're infected. So yeah, it's the probability of symptoms given infection. And we consider that to be different by age group, and we considered it to be lower in the first sort of 3 to 4 10-year age bands. So children and young adults were considered to be less likely to be symptomatic if they got infected. And we considered that symptomatic people were more infectious than asymptomatic people. So it's a little bit indirect, but because more of the older people are considered to be symptomatic, and because symptomatic people are more infectious, effectively those people per infection will contribute more to the infectiousness.
Thank you, Dr. James. Somebody asked for the link to the model of presented earlier. I think it was posted in the chat box by Dr. Jamie. Okay, another question here. What could be the reason for the underestimation in the death count?
We would love to know that. That's a question we've really been trying to understand. We first thought it might have been driven by the age structure, even beyond what was already included in the model somehow, that we have the infection fatality rate off, and with such a younger population, that could cause the lower death rates. But we're really not sure what's driving that, and we'd love for some feedback if people had thoughts on why the death rate is low. I mean, it's a great surprising result. We'd just like to better capture it in the model so we can provide better estimates of expected mortality rates.
Yeah, I agree. Modeling is really a dynamic thing. No? It doesn't end. Okay, here's another question. In workplaces and schools, did the models take into account the movement of people? The movement of people across borders?
No, each of the 4 models that we've presented, sorry, Jamie, maybe I should let you answer this one, but each of the 4 models we've presented, including the 3 subnational and the 1 national model, are totally decoupled from one another. It's been I guess it's been hard enough. They're quite complicated models when you think about all the complexities of transmission. So it has been hard enough to even get adequate calibrations for each of the 4 models without yet considering importation and transition of people between the geospatial patches.
Yeah.
Thank you.
And I think a way to do that a bit superficially, rather than having a true meta population model where you have one model with these subpopulations, is to allow for importations from different areas, which is possible. But we haven't done that at this point, partially based on conversations that wasn't considered to be something of concern right now, but it certainly was on our radar that as borders open up more and people start moving more, that might become a much bigger issue that we need to consider.
Okay. Okay, thanks,
Yeah,
Jamie.
particularly for maybe some of the regions we're not simulating, I suppose, if there's very low case rates because we've focused on applying this model to the regions with high case rates, and importation we assume is, I guess, less important in those areas, but that might not be the case for other areas. Yeah.
Thank you. Here's another question. Could the reason for the modeling in Central Visayas be the geographical makeup, meaning the landlocked versus island provinces?
I'll give you all the hard ones, Jamie.
That's maybe
Well, I'm wondering what aspect of that the person who asked the question is thinking of it. Does it have to do with importation, or is it more geography and climate and other factors outside of human movement?
maybe it's the geography that could affect the mobility of people.
That certainly could be the case. We've tried to capture mobility in multiple ways, as we've showed, but we're not sure that actually adequately captures human mobility. And it's possible that the way that restrictions and people have responded in Central Visayas is not reflective of the ways that people have responded or are moving in the other locations that we're modeling. And I'd be really keen to continue that conversation with Ateneo University if you think there's something there that we can improve upon, because we would like to get Central Visayas in better shape.
Yeah, and I guess like just to highlight or to stress, the difficulty has been capturing the trends over time. We can actually if we just want to hit one data point or the last data point or something, we probably would be able to do that. And even reconciling deaths with the number of cases that are coming through recently in Central Visayas, I don't think that's been particularly difficult, but the real difficulty has been that the fluctuations in case numbers have gone totally almost to the opposite of what the model's predicting, and the model's predictions are driven by Google mobility data. So for whatever reason in that region, the Google estimates of mobility don't help us to sort of get that trend over time that we might like.
Okay, this last question was actually taken from the previous question from the previous session, and we said that we will listen to your presentation first before we can answer the question, because it's more related to the opening of classes. Based on the output of your model, what insights can we get regarding the opening of classes?
Well, the takeaway for me right now, which has been really interesting, and I'll just emphasize that these are a range of possibilities. And of course, as restrictions change, ease and get stricter, things will change. But looking at the different trajectories, for example, Metro Manila versus Calabar zone, what we're seeing is that if you allow kids to go back to school after the cases seem to be under control, it doesn't seem to cause a second peak. It just slows down the decrease in cases. And so I would think that suggests that it might be okay to open schools, but not when cases are on the uptick after you're starting to control transmission in the population. And that's also based on the assumption that kids are getting less severely affected and potentially transmitting less than 2.
Thank you
James,
very
did
much.
you want to add anything to that?
Yeah.
I mean, I think like our model is fairly sensibly parameterized to that in relation to age groups. And yeah, I guess it's just to reinforce that we're not really comparing like with like, I suppose. Like 75% of schools back, the model is currently assuming that school contacts are at absolute zero, that all schools are closed and there is no contact in relation to childhood education whatsoever. And so I guess the message is that returning 75% of schools to normal is the equivalent of taking workplaces from what they are currently to 75% of normal. Is that correct to say, Jamie?
Yep.
Okay, there are no more questions. That ends our second session for today. Thank you very much, Doc James and Doc Jamie. Thank you very much for your presentation and explanations. So we now turn over the floor to Andre. Andre?
Thank you, everyone. Thank you, Doc, and to all the speaking Dr. Find remark. Please form with you have a tayong to close task force T3. Good morning, sir.
Good morning, Andre. Can you hear me well?
Yes, Doc.
Okay.
Good morning, Doc.
Hi, LV. Good afternoon to everyone. Well, thank you for this whole morning of sessions. I attended from the very start. And so we had 7 speakers. And first of all, I'd like to thank all of the speakers, starting with Usec David, who opened up the session. And then, of course, in quick succession, LV, Raymond, Anna-Marie Cabasal, Jerry Cruz, and of course, our last 2 speakers, Professor James and Professor Jamie. A lot has been talked about this morning. And perhaps I might just say a couple of things about this morning's session. It brings to mind really a couple of questions of what do the models tell us about the progress of the pandemic, particularly in our country? And the second is, how do the models actually help with policy making and implementation? As we all know, we have to be careful, as Elvi says, of course, Professor Jamie and Professor James, that these are models, that these are straw men that are actually created in order to try to depict reality. Reality is far, far more complicated than the models that we create. And I remember very, very early on when I was working in HIV in the 1980s, people created models. And one of the models that was created was just predicting how many HIV cases we'd have at the end of the year. And our experience there was that we overpredicted all of the predictions. We were saying that in 15 years, we would have 200,000 cases of HIV in the country. When 2000 came around, the turn of the century and the decade, we actually had about 2,000 cases in the AIDS registry, which shows you how far we had missed. Back in the 1990s, I was trying to get LV to model the spread of cholera in Manila and to predict its seasonality. And we never got around to doing that. But lo and behold, 15 years later, we're modeling COVID-19. So I guess that's the first point. And as Jamie and James actually said, when you have to have a model, you actually have to validate it with the actual data that you're collecting. And if reality changes, the predictions or the estimates of the model would actually be off target. I think that's the first thing that we need to realize about this. But having said that, I would congratulate all of the mathematical modelers that have come and produced faster. Because as we can see, the platform is so elaborate now that it allows estimates and predictions in areas of security, in areas of economics, as well as in areas of health. I guess the second point is really think about these models and how they're useful for decision makers. We've had one morning listen to all of these models and what they estimate and what they predict. Imagine, for example, the IATF listening to 2, 3, or 4 models, estimating the progress of the epidemic and its predictions, and then having to make decisions on what to do. And here you can see that models and the evidence that they may present will now mix with all of the different factors for decision making, from the political, from the economic, from media, okay, and what media says. And so I guess as we come away from this webinar, I would say I'm very grateful for all of these presentations, because what they eventually allow us to have is some handles, some conceptual handles for thinking about how this epidemic is proceeding. For example, one of the takeaway messages that was mentioned, and I think it was Jericho, not only Jericho, yeah, Jericho said that, one of the messages is that, testing, contact tracing, and isolating are really, as the models say, the main things that have to be done very well. I think we keep repeating that message to ourselves. But when you think about it, it's really difficult, particularly with COVID-19, because there are already inherent delays with COVID-19. The fact that you can transmit even when you're asymptomatic makes it so inherently difficult to capture a transmitter and isolate them immediately, much less contact trace them. And so I think the message to all of us eventually is that we have to already, even before we test and contact trace, already behave in ways that are going to minimize the spread of infection, from contact tracing and physical distance, from physical distancing and social distancing, and just avoiding, all of the occasions in which this virus is going to transmit. I think that really is the message for all of us, even as we think about these models assisting us map the way the epidemic spreads and make predictions for how they're going to be 2 or 3 months from now, and making the decisions for how, for the interventions that we as a country and government will have to implement. So I'd like to end by thanking all the speakers. This has truly been an enlightening session. Thank you for all your work. To all of the audience that are going to use all of these concepts and these models for their own work, and also for their own advocacies and advisories to people who need to understand what we're going through in this epidemic. Thank you all very much.
Thank you so much, Dr. Reed. Thank you.
very
Yes, sir.
much, Dr. David, for that one. To everyone, I turn the floor Winfer to master group photo. Paki-on po na. Maraming salamat. We'll see you tomorrow on day 3. Winfer?
Okay, so just I'll wait for about 15 seconds for everyone to open their videos. Sharing the images now. So just stay with your smile for about 10 to 15 seconds. Okay, so okay, 3 more. 1 last. Okay, thank you, everyone.
Thank you.
Thank you, Winfer. Thank you. Thank you, everyone.
Thank you, Elvie.
Yeah,
Thank you, Rina.
tomorrow.
Thank you, everyone.
Thank you.
Bye.
Thank you for the enlightenment.
Salamat. And to Dr. David.
Thank
Thank
you
you.
po.
See you tomorrow po, the day 3.
Congratulations.
Bye.
Thank you.
Po,
Thank you,
bye.
Usec. Thank you po, sir.
Thank you po.
Thank you, team.